Well, good morning, everyone. At least it's still morning here in Nebraska. We'd like to welcome you to the 2024 Symposium on Substance Use Research. My name is Mary Emery. I'll be your moderator today. I'm the Director of Rural Prosperity in Nebraska here at University of Nebraska-Lincoln, where we do quite a bit of work with rural communities throughout Nebraska, and many of those communities now consider health a primary issue. Just a few reminders before we begin. This session's being recorded, and we will send an email to all the registrants and post on social media when the recording is available. Also, this session is a webinar, so you attendees will be muted. You can use the Q&A to send questions to us, and we'll be checking them regularly. And we will try to answer as many as possible as time allows. So I am very excited to introduce today's speakers. We've had an opportunity to visit a bit, and I think you'll find their ideas and experiences of great interest. We have three experts joining us today across a range of disciplines to address the issue of substance use disorder in rural health. So Dr. Raj Masi will join us, Dr. Alexandria McMadoo, and Dr. Gordon Smith. So I'd like to take a moment and ask each of them to do a brief introduction. They'll share a little bit about their background, their research areas, and their experience that's relevant to this topic of rural health and substance use disorder. So Raj, would you like to start and introduce yourself, please?
Sure. Thank you, Mary. Thank you to all the attendees. It's certainly an honor to be here. So my name is Raj Masi. I live in Grant County, West Virginia, one of the smaller counties in West Virginia. I work statewide, but I reside in a town with 2,500 people. I have a background in medicine, particularly emergency medicine, public health. I work for the West Virginia Office of Drug Control Policy, and we work on initiatives to reduce overdose deaths throughout the state. I am a research professor at Future Generations University, and my areas of research are overdose predictive modeling, wearable technology, remote patient monitoring to detect and predict cravings, anxiety, and depression, recognizing that these are precursors for relapse and overdose. Capturing unreported overdoses and community-level naloxone distribution through a novel QR code system, which we just implemented, and also tracking physician and other prescriber utilization of the West Virginia State Prescription Drug Monitoring Program through surveys and see barriers and ease of access.
Thank you. Dr. McMadoo, you're up next.
Hi, everyone. So first of all, it's such a pleasure and an honor to have the opportunity to speak with you all today. So my name is Alex McMadoo, and I'm a fairly new assistant professor in the Department of Epidemiology at the Brown School of Public Health. So I am physically located in Providence, Rhode Island, but much like my two counterparts on this panel, I also have connections to West Virginia. So and that has definitely been a tremendous driver of my work. So I'm originally from a tiny town in southern West Virginia called Pineville. It's a population about 500 town, and really growing up in the 90s and 2000s, really seeing the degree to which the overdose crisis ravaged my home community is really the driving reason why I found myself doing this work that I do. The majority of my work is focused on harm reduction and overdose prevention work, and I'm particularly excited to one day get to kind of continue to establish a research line that's focused on rural Appalachian communities. Much of my work here in Providence has also been focused on overdose prevention, and I have a particular interest in understanding how members of our social network influence our individual overdose risk and overdose risk behaviors. So super excited to have the chance to chat with you all today. I will now pass it over to Gordon.
Hi there, I'm Gordon Smith. I'm a professor of epidemiology here at West Virginia University. I'm a physician epidemiologist and an immigrant from New Zealand. Legal immigrant, I might add. Went through all the hoops given the current issues. I got my medical training down in Dunedin, New Zealand at Otago University, and then worked in New Zealand doing rural general practice. I came from a small little country town of 3,500 people in a rural, very much a rural farming area of New Zealand, where my dad was a country GP. Then I sort of did a whole variety of different things in pediatric internships and went and worked in Australia. And then I spent 4.5 years in Papua New Guinea, and that's what got me addicted into public health. And I realized that as a physician, just relying on treating, I was sticking my finger in a dike. Really public health was the answer. So then I came to the States, did my Master's of Public Health at Harvard School of Public Health, met my wife who's American and got stranded here, and I'm still here at the moment. Then basically I worked at the Centers for Disease Control as an epidemiologist, did their field training program in Colorado at the State Health Department, doing all sorts of weird and wonderful diseases. And then came to Atlanta, and I was CDC's first full-time injury epidemiologist many years ago as a preventive medicine resident. Then I went to the Harvard School of Public Health, and that's where I really got interested in the whole issue of injury research. And I'm particularly interested in the whole issue of sort of death certification and medical examiner and better understanding the drugs from the medical examiner point of view and what are the drugs that are actually killing them. Because the one thing that really fascinates me right now is that we're doing some analyses of the survey data for West Virginia. And West Virginia has usage rates of almost all of the drugs very similar to the US. Yet we have a drug overdose rate that's double the US rate. And so what we basically, if we have a similar number of users, why is our case fatality rate so high? And that's why I'm down here right now in Princeton, trying to understand that by doing some detailed case investigation of the drug overdoses and getting a much better understanding as to how we could develop prevention strategies and harm reduction, particularly in the current political climate of West Virginia.
Thank you. So let's get started and sort of set the stage for our listeners. When you think about your work, what are the primary factors contributing to substance use disorder, substance use issues in rural areas compared to urban areas? What makes rural different and challenging? And who would like to go first?
I can jump in. So one of the things that I think is important to talk about in distinguishing rural and urban populations, if we go really downstream to early onset of use, which is where everyone starts. If we look at, when are youth most vulnerable, this is, during times of transition, obviously elementary to middle school to high school to college, starting a job, disruptions in their lives. If you look at that, so we can look as an example of a successful intervention, which is like the Icelandic model, where they said, kids with downtime, with idle time, are vulnerable and susceptible to using substance use disorder, substance use as a coping mechanism for life stress. So in urban areas, a kid could walk out of their door and probably ride their bike or walk to a climbing wall, a gym, a YMCA, a swimming pool, a skate park or something. Whereas, as Mary, in Nebraska, and it's very similar in West Virginia, that, things are really spread apart. There's a lot of isolation. And so it's difficult for vulnerable youth, to access those type of evidence-based alternative strategies that can help mitigate the risks of early substance use. So I think that's important to recognize. Secondly is the impact of adverse childhood experiences. I think that's really important for us to understand the impact that has in rural communities compared to urban areas. Abuse, neglect, household dysfunction. These are all things that can lead to substance use later in life. And so the mitigating things that can help early on are less prevalent in rural areas compared to urban communities. And then one of the things that I know Alex and Gordon can attest to is in our particular slice of the world, we have a concept called Appalachian fatalism. Appalachian fatalism, meaning that we believe that outcomes are beyond our personal control. And so one of the things we looked at was, trying to distribute, if people are dying of overdoses and they're dying from fentanyl, well, by golly, let's give out fentanyl test strips, test your stash. And so one of the things, and we looked at was, hey, will you use these fentanyl test strips? If so, and why not? And so, so some of the feedback we got from participants when we were studying this was, if it's my time, it's my time. And so that is fairly pervasive in at least in West Virginia. And I think another issue that we need to understand is in rural areas, if you look at as a precursor to specifically opioid use disorder, a lot of times it is chronic pain sustained from a work-related injury. The types of work that people do in rural areas are different. As people work in mining, they work in logging and timber production and chicken plants. And this is all very manual work, which results in physical injuries that can then open the door and set up those kind of neural pathways for a substance use disorder. So those are some of my thoughts on primary factors contributing to substance use in rural areas compared to urban.
Yeah, I will follow on from that because I think he really hits the nail on the head. But to me, and one of the things that I'm being particularly interested in is following really the evolution of the drug epidemic in West Virginia. Because we've been looking at the prior to 1990, drug overdoses were in the category called accidental poisonings. And when we looked at accidental poisoning rates, they were very flat in West Virginia, and they were really significantly lower than the US average. So we start off at 1990 with essentially a drug overdose rate lower than the national average. And now we're at the state where it's far higher than the national average. And the Big Pharma basically created this. They identified, and we're tracking down a lot of these documents, which has been rather fun. They identified areas with high disability rates, which is exactly what Raj was saying, areas where there was a lot of manual labor, where people had pain. And then we had this advent of the time where pain is a third symptom, is a vital sign rather, and no one should suffer pain at all. And then the magic bullets came along in the way of OxyContin and various things like that. And so we had this huge increase, and we have all these, particularly down here in southern West Virginia, where I am right now, vast amounts of opioids prescribed and sold through the pharmacies, because all the doctors got very good detailing from the drug companies showing that it was a real problem. And but then in West Virginia actually reacted to this, which very rightly they should do. In fact, they were suing the drug companies even way back then in some of the cases that were hidden, and then released by the court later on. But the fascinating thing is that then they did what we normally think we should be doing as a public health measure. We clamped down on prescribing. We set up a prescription drug monitoring program. And we were very effective at changing prescribing practices. But unfortunately, we abandoned a lot of people who had a very severe, though we all know friends who have tried to stop smoking, that's hard enough, let alone trying to stop a drug addiction when you're opioid dependent. And that really started us off in this horrible spiral. And that then combined with the whole sort of loss of job, the population decline in West Virginia is just phenomenal in some of these towns. McDowell County is the only county in the US where they closed a Walmart because there weren't enough people. So those are some of the issues that I think have to be thinking about. It's really almost a medical addiction of the population. And once set up with the despair and everything else, it has just created this huge problem that we really are trying to deal with.
Go ahead, Alex.
Both of you. I feel like you both touched on a lot of themes that I think about when I think about this issue. Yeah, so in many ways, sorry, Gordon, you touched on the piece about despair, and I think that that's one kind of parallel between substance use in rural areas as compared to urban settings. So that being just much of the same, like just the absence of hope and the absence of opportunities due in part, a low rate of job creation and the conditions of capitalism. So articles have been written extensively about some of those parallels in the economic conditions between inner cities where crack cocaine use proliferated in the 1980s and in rural Appalachian communities that were, ravaged by the prescription opioid crisis of the 90s and the 2000s. So in both of those cases, people came in droves, both to inner cities and to Appalachia for economic opportunities. And those folks were then abandoned when the industries left. So I feel like in much of Appalachia, you have this kind of exodus of young people and an exodus of jobs, and these abandoned coal towns, to Gordon Smith's point, when you mentioned, the decline in population, McDowell County was the first thing that came to mind for me. That's in southern West Virginia, just a little south of where I grew up. And the retraction of the population there is just mind-boggling. So anyway, so after folks left, you then have this kind of populace of folks who are left behind, who are underemployed and remain there, feeling a bit hopeless and fatalistic, to Raj's point, and both of which are associated with substance use. Then, as compared to inner cities, to Gordon's point from earlier, drug use in Appalachia was largely fueled by big pharma and the influx of prescription opioids in rural and predominantly white communities. As you noted earlier, these corporations, these pharma companies really targeted communities with high rates of people with disabilities. But I think it's also important that much of Appalachia is predominantly white, and the early issue in prescribing was born out of doctors' trust of their patients and this belief that, white patients would be less likely to, in quotes, misuse their prescriptions as compared to Black Americans. You can almost imagine a counterfactual, like wherein if much of the populace of Appalachia was Black, in fact, that articles have been written that being Black was actually a protective factor in that first wave of the overdose crisis. So that's a worthwhile and component of the issue to note.
Thank you, Alex. So in my field, which is sociology, you use the word despair, Gordon, and so the demographers have been looking at the deaths of despair. This kind of combination of poverty, of lack of opportunity, lack of hope, and that's that connection to opioid use. So when we think of the deaths of despair and how that's impacted people around those who have overdosed or who are using or trying to be in recovery, in what ways does the deaths of despair, the substance use disorder, impact community and economic development in rural areas? What have you seen as the impact on community and the economy from this epidemic that you've all been describing in West Virginia?
One of the things that we've
Go ahead.
noticed in rural West Virginia is that, there's the one of the sort of spin-offs from this are now the workforce challenges. So not only do you have in rural areas, especially a smaller workforce pool, but with the addition of substance use disorder into the mix, so now that workforce is even further diminished. And in addition, there are employers who will hire anybody to do this job, especially in like poultry industry or logging and stuff, to hire anybody. And so there are many people who we interact with who are, currently using methamphetamine or opioids while at work, which of course leads to, work-related injuries, so all of these things add to the financial burden to employers and ultimately to the community. So that's sort of one of the things that we see, at least in rural West Virginia.
Thank you, Raj. Alex or Gordon, any thoughts on this one?
Yeah, and I think when I was sort of relating my little history of things, as I say, it started off with at a period of time when there were a reasonable number of jobs, and we also know very clearly that when in times of unemployment, the workers' compensation claims go up and those kinds of issues. So what happened here is the jobs went away, the people were still using opioids, and I think that's what sort of set up the economic conditions, because the job losses in some of the worst communities is just phenomenal to see the job loss in that. And we also know that having a job is it's very important for self-esteem and how you're perceived in the world. And if you don't have a job, it causes all sorts of other social problems related to that. And some of the poverty down here that I see is just like very much I've seen in parts of the third world that I've worked in. And that in terms of even policy around this, there's been so little done in the past to address these issues that we make a social decision that we don't want, that coal is polluting and we should close down. We as a society make this decision. Therefore, we have some obligation to deal with what's going on with the people that we're just shutting down their jobs. Many years ago, in some of the industrial states, there were a considerable sort of societal investment and retraining programs once they decided to shift the jobs to Mexico. But that was never done here in West Virginia. And that's part of this hopelessness, the fatalism that Raj talks about.
Alex, any thoughts on this question?
Yeah, I'd be happy to jump in. So I would say that, on one hand, acute substance use disorders can affect workforce participation, but I think that the systems level and business responses to the drug use crisis in that region can be even more damaging. So drug testing, either at hiring or over the course of employment, systematically removes people who use drugs from the workforce. Although, of course, to Raj's point earlier, we do want to prevent injuries. But so in non-Medicaid expansion states in particular, these folks then lose access to their health insurance, which is then a necessary prerequisite to engage in evidence-based substance use treatment for most people. So loss of employment in itself then prevents folks from engaging in treatment, and then is in itself a stressor that can exacerbate drug use and overdose and risk behaviors and increase risk for overdose for a lot of folks. So instead, I think that states should be focused on increasing access to harm reduction supplies to keep people safe and to access evidence-based treatment so that, services are available for those who want it. And, to Gordon's point earlier, it's really, I think, just tremendously important to ensure that our policies and our approaches are keeping people in the workforce to the greatest degree possible.
So you've all talked a lot about how important job loss is to understanding the issues around substance use, and particularly when we're looking at an industry that is sort of laying off across the board. We have urban areas that are part of that, oftentimes referred to as the Midwest Rust Belt, where there's been those kind of systematic job losses as well. When you think about what the issues are in rural areas around coping with job loss and how that relates to substance use disorder, are there other factors that are part of the rural environment that make substance use disorder look different dealing with it look different in urban areas compared to rural areas? Or 'cause we do have this commonality around job loss.
I think one of the things that I see, and I'm sure Alex and Gordon see this also, but from a social standpoint, like there's been this entire generation affected by the opioid crisis in West Virginia, and one of the spin-offs from that is there's a generation of grandkids that are now being raised by their grandparents. So these grandparents who've worked their whole life, now they're on a fixed income through their Social Security or through Medicare, and they are now taking on this new burden of raising. They've stepped up and they're taking care of these grandkids, which further dilutes their their income and their ability to live a thriving life. So that's something which is really this grandparent generation has been really disproportionately affected by this. And I'm sure Gordon might have some data on how prevalent that is in West Virginia, but it's significant.
Yeah, I don't have the numbers on it, but it really is significant. It's a major issue that you addressed in many of the surveys that have been done, and that you got. Oh, and I think part of this is the generational keeping the drug problem going. We have 14-year-olds being given drugs. I remember some of the time we've gone to drug courts, and the parents have given drugs to the children, 14 and 13-year-olds. And so it's sort of an intergenerational problem going from the initial start that I described earlier, but now it's sort of endemic in the whole community. And that's partly what makes it so much more difficult to think about how to deal with.
Yeah, and to your point, Gordon, and I'll likely end up talking about this a bit more later, but the piece about substance use in the region being intergenerational, I think also contributes to, particularly in the context of like this ongoing overdose crisis, right? Where most people know many people who have overdosed. And oftentimes those people who know who have overdosed are their parents or and other like close family members, which I think really contributes to this community level kind of ongoing persisting trauma that the community is really experiencing and has been for the past 2 decades, which in itself then further exacerbates substance use and overdose risk.
And I think that's the issue that Raj talks about with the ISIS, the children's that whole issue there. There's a whole generational issue. And I think that I think is the real crux of what we need to try and figure out.
So earlier, before we were joined by the audience, we had some discussion about how different rural is from one place to the other. But one thing that people often associate with rural communities is that the community social networks are stronger. In a small community, everybody knows everybody. And there's a rural culture around, pulling yourself up for your bootstraps and being responsible. And then there's also this challenge that in many rural communities, your ER, your EMS and your fire may be run by volunteers. So there's not that kind of professional support that you can just call and folks will show up. So when we think about overdoses, what kinds of things do we need to think about in terms of policy and practice that address these challenges in rural areas that are somewhat different than in urban areas?
Just a comment. So Gordon gave us some dismal statistics of West Virginia compared to the nation, and I'm happy to share through the Office of Drug Control Policy that our data for the past 2 months shows literally for the very first time a 34% reduction in overdose deaths. So some of the things that collectively we're doing as a state is panning out. one of the things for rural social networks, I think, is really important to understand. And there are similarities between rural and urban, and of course there are differences. So one of the things that we've noticed is that, for the most part, people don't use drugs alone. They have a drug using ecosystem. People are purchasing, sharing, procuring drugs. And so that is something that, we have tried to leverage and harness in our overdose reduction sort of techniques and methods that we use. So one of the things we do is like similar to COVID-19 contact tracing. So we do overdose contact tracing. And so one guy who overdosed, we know that he uses with 5 other people. So we're going to use that as a workforce multiplier to give him Narcan, to give to 5 other people, potentially fentanyl test strips, xylazine test strips, metamidine test strips, things like that. So we use that social network to leverage it to enhance our footprint to give out life-saving medication. So that's one aspect to it. And the other is that in rural, if I was in downtown Baltimore and I knew that there were 10 people, in a park using drugs that I wanted to immediately within the next hour get outreach to, it might be difficult for me to find 20 people to be part of an outreach team. In a rural area, conversely, because of factors you mentioned, Mary, everybody knows everybody. I went to school with that guy, I played ball with him. I could find 20 people to come and do outreach right now. They would drop everything and come and do that. So that I believe that's a significant value of having a rural social network in the context of overdose.
So I'd love to jump in here. I have a bit to say. A bit to say specifically about some of these differences between rural and more urban social networks. So as part of my dissertation research, I was really interested in exploring how knowing someone who overdosed influences individual overdose risk behaviors. And we found that for some, after knowing someone who was overdosed, they found that experience to be protective, like oh man, that could happen to me, I need to watch myself. Whereas for others, for other people who use drugs, we found that particularly if that overdose was witnessed or was fatal or occurred to someone who was really close to you, like a partner or a family member, we found that those folks tended to increase their use to cope with those feelings of grief and bereavement, loss, and and potentially that trauma. So in rural settings, to Radha's point, we know that drug use networks are much more frequently kinship networks. You might be using their cousins, siblings, parents, children. And I believe that the impact of these overdoses are much more emotionally salient, and that the overdoses of these close social ties are, I believe, an important social driver of overdose risk behaviors and subsequent overdose in this setting. So an early experience or an early conversation in West Virginia is really what drove my hypothesis in doing this work as part of my dissertation. Back in 2013, I was conducting interviews with people who use drugs in southern West Virginia. And I remember sitting with a woman in her trailer. This is a woman who uses drugs. And I was out, conducting an interview about her drug use and asking about the most recent overdose that she knew about and how it affected her. And she started telling me she told me the story about how she had lost her husband to overdose about a year ago, and just a couple months prior, she had lost her son. All 3 of whom, were used sometimes together. And she was the one who called 911 when he was overdosing. And she said that she heard on her scanner the guy on the line saying, oh, it's going to such and such's house again. Like, he's just a druggie. Like, I hope, like, how many times do we have to respond to this guy? And she's telling me the story with tears in her eyes, like just the stigma and the trauma is just so compounded for so many people in that community. So I guess kind of going back to my earlier point, or to your question, I think that trauma-informed interventions that, appropriately allocate resources to these next of kin and to other network members and familial survivors could be really potentially quite impactful in the region. A nice quick little example of that is, in New York City, their OCME has a program where they have a team of social workers who reach out to these next of kin of overdose decedents, just to give them a call and ask, what resources do you need? Like, how are you coping? And to be able to, and the social workers then connect them to the resources and in some cases therapy and care that they need. And I'd love to see that type of work replicated.
Yep, and I fully agree. The thing that fascinates me is the connection, how everybody knows everybody. I've been sitting here now actually linking our medical examiner data with the local reports, and they know all the cases. They know people. They know people's relatives. And I firmly believe that we should be taking more advantage of these fatalities as an opportunity to do intervention. And that's actually what we're doing as part of this project here. And our aim is that whenever a death occurs, we then go out and do and immunize the population around that case. Essentially using the smallpox model they couldn't eliminate smallpox when they just tried to vaccinate the whole population. But it was only when they went out and whenever there was a case, they would go and vaccinate around each rare case. And that then provided the protection. And so that's what we're just beginning to do here, is to go out and identify areas where the fatality occurred, and then go out and give more resources to the local community, including naloxone, because we may have identified a naloxone desert. And that's one of the things as part of this project, we're trying to understand that so that we can better plan for how to do this, which is what I think is an important aspect.
Thank you. So kind of thinking about all of these issues we've talked about, and we've talked about how different rural is. In my work with people concerned with substance use disorder in rural communities, and, again, Nebraska's very different from West Virginia. The topic of stigma has often come up as a barrier, not only in treatment, but also in prevention and recovery efforts. So one of the things that we found in extension is that sometimes the people with the strongest stigma are found in emergency rooms or police forces, where they could be part of that outreach team you mentioned, Raj, that could help out, but instead they're saying these people deserve what they get. And not only that, we found there was kind of this mantra to the stigma. So there would be this initial communication about, oh, it's so terrible and we really need to help these people. But, it really is up to them. They need to figure this out. And if they can't figure it out, then they need to be punished, or they need to do this, or they need to do that. But we found that same mantra explaining other things in the community. For example, why don't kids of color graduate from high school? Well, we feel really sorry about that. But if their family was just more supportive of them. So when you think about these close ties in rural America, these challenges we have with the economy and jobs, and then here are these people that have suffered trauma and they're trying to find a way through it. How is stigma and these messages influencing what's possible? And what can we do about it? Who would like to take on that one?
I would just like jump in and say, I think the word stigma is like too sanitized. I think we need to really break it down into, we just really hate, disgust, fear. These are the true elements of this. And I know for example, again, looking downstream at the onset of substance use, when we try to, bring an evidence-based program to a school system, And we know that, we have to focus efforts on prevention to prevent these effects. And so many times when we try to bring it up and talk to a school board or something like that, well, we don't have that problem in our school. We don't have that problem in our community. We don't need this. And really, if you dissect that, it's stigma. Similarly, when we try, as you know, rural communities, Mary, I'm sure Nebraska, you've experienced this, the pillars of so many communities are the faith-based organizations. And these should be places where people can turn and get help. And instead, they happen to be some of the most judgmental, stigmatizing sort of organizations. And when we try to talk to pastors, hey, would you consider doing this program as part of your church outreach? And, no, we don't have that problem. So I have experienced that as a barrier in rural West Virginia, that, a lot of times doors are shut because of these preconceived notions. And again, this is a huge challenge, even in the recovery community. In the recovery community, the stigma is so prevalent. Like the guy who drinks alcohol feels he's better than the person who's doing prescription pills, who feels they're better than the person who's shooting up heroin. So that is even pervasive in the recovery community. And we try to level the playing field, through education and stuff. But so yes, that's a big challenge.
Yeah, I'd be happy to jump in. So stigma at the individual level is certainly, a significant barrier to, for example, engaging in treatment. But I think also importantly, stigma, or, really to Raj's point, sort of given the sanitation of that word, like that we discussed, for this population that's so pervasive in that region, really drives our policy decisions. So, the absence of harm reduction resources and accessible treatment is driven entirely by stigma within our communities, which is then reflected by our policymakers. So, for example, stigma and, all of these negative perceptions of people who use drugs really drove regulations around syringe service programs, for example, in West Virginia. So these were once pretty thriving programs in some of our kind of largest towns. We don't really have major cities. And just a couple of years ago, those were forced to switch to a pretty strict one-to-one exchange model that rendered these programs almost impossible to operate. Similarly, West Virginia is a little bit unique in that they also have a methadone moratorium. It is not possible to increase the number of providers of clinicians like offering methadone in the state, because there's been a moratorium on providing this treatment, and that moratorium has been around for how long? Raj, is you nodding? What, a decade?
Yes.
Or at this point. So stigma drove these policies and regulations that have made it really very challenging to tackle the overdose crisis in that region. And so by reducing stigma, we can then, reverse these policies and regulations to ideally enhance our impact.
Yeah, and I would comment, I think I like Raj's comment that with not only stigma, it's disgust and all of those, I don't want anything to do with them. And I think it's in a way much higher in the politicians than it is in the general population. Because the general population, we all have people here all have family, all have people they know very closely who have died. And I don't get anywhere near that level of stigma and disgust from the people that you talk to in the street and the people that I work with in the communities, although it's probably biased because they're involved in the substance abuse treatment, otherwise they wouldn't be there. But the utter disgust in the politicians is just horrific. And I've been down there trying to defend, to get them to release the regulations around the syringe services program in the past. And it is just horrendous to hear the comments from the politicians. And to me, one of the biggest things is, how do you get the politicians to be more informed? People like Raj have been trying for years, and do the Feinberg who I work with. It's just impossible. But here we have proven interventions, as Alex mentioned, up in Rhode Island, for example. They really are doing very enlightened programs about syringe services programs. And yet you have it like down here in Mercer County, they closed it down. It was run by the health department. They couldn't meet the criteria. And there was this most wonderful mobile syringe service program run in Wyoming County that we helped them set up way back. And it's been shut down because doesn't have a doctor on board within immediate radius. I can't remember all the exact, but anyway, it's all hogwash. To me, that's our single biggest challenge is to be able to implement in a place like West Virginia modern practices with regard to the way we deal with the problem.
So we had a question from our viewers about how is methadone and treatment and other kinds of medication treatment coverage rates in West Virginia. Is it easy for people who need it to get help? You hit on that a little bit, Alex, but if anybody else wants to add to that.
So fortunately, in West Virginia, Medicaid covers buprenorphine, at least the oral form. It covers methadone. It covers Vivitrol, which is, as you know, $1,800 a shot. So we're very fortunate that way. But it's not easy to get into methadone because of things Alex was talking about, moratorium on opening new OTPs, opioid treatment programs. So that's a barrier. But yes, we have good coverage in our state. All 3 Medicaid MCOs covered.
I'll also note that the rurality of Appalachia also significantly constrains the accessibility of methadone and other medications for opioid use disorder. So, for many people who are living in kind of these far-flung communities, you may be driving 30, 60, even 90 minutes just to access treatment. I think a wonderful example in the town I grew up in, I have a cousin who was driving an hour away to New York City, to Beckley, to access methadone treatment. He was, because substance use disorder is, as some people think Jody Rich famously called it, a chronic relapsing disease. He had a recurrence of use, was booted from that program, engaged in another, had a recurrence of use, was booted from that program, and then was out of options. So from there, I think the following year, he then engaged in was able to enroll in a program in Charleston, which is a 2-hour drive from where he lives. So the accessibility, just the rurality of the region and the methadone moratorium greatly diminishes the accessibility of treatment.
Yeah, and I think you're right there. The whole transport and the rural transport is a major issue. And the interesting thing is, talking to the folks down here in Southern Highlands, was when when COVID came along, they had they moved over to telephone consults for much of their work, that the number of no-shows went down dramatically. And when you look at these no-shows, the no-shows often is transport, the car broke down, they lost various things like that. It's not just a matter of, and that's going back to Mary, your issues earlier about difference in an urban versus a rural thing, is the access of services. But I will say that being a Medicaid state, they've done a huge amount in terms of increasing treatment here, and the access to the drugs and the things. And if it was, and I think that's probably part of why Raj is seeing this wonderful decline in the last few months, and some of the decline is that the availability is better. But I think transport, as Alex said, hit the nail on the head. Some of that thing is a big issue. And then if you miss an appointment, then you might get thrown out of the program, all of those kinds of things.
One sort of in commenting on Dr. Smith, that's a really, the accessibility Alex brought up, and Dr. Smith, what you're talking about. One of the cool things that has kind of just recently happened is we have now, when we get overdose spike alerts, we deploy outreach teams, which are peers and social workers and people who care, homeless advocates, and we use one of the 2 licensed telehealth companies with it's called Pursue Care, with a tablet, and they can right there on the spot. We can get presumptive eligibility for Medicaid within like 3 minutes. We can link them, we can enroll them through the portal, and they get an appointment with provider. And most of the time, they can get a dose of buprenorphine within anywhere from 3 to 6 hours. And so they do really cool stuff. They have a drug testing, which is a DNA matched oral swab. So you can't give your son's urine or something. It's DNA matched to you for every subsequent sample. And they also have their own pharmacy, which getting it from a pharmacy a lot of times is a big barrier because they won't carry it. So they have their own pharmacy that can ship it to the patient. So that has really been a game changer for us in rural West Virginia.
Just jumping off of that briefly, Raj, I am totally thrilled to hear about this like increased utilization of telehealth for medications for opioid use disorder in West Virginia. That's just incredible. And I love that it's, we're already seeing some impacts. Before this talk, I was kind of, scratching my brain about thinking about, other opportunities for expanding access to treatment in that region. And the 2 other, I think, opportunities that, the region could capitalize on are mobile MOUD, although for increasing telehealth, that's fabulous as well. As along with pharmacy-based distribution of MOUD. We've had some success with programs up here. In my thinking, that pharmacies tend to be a pretty fabulous way to reach the population. Opioids obtained from pharmacies is how this overdose crisis started. So obtaining treatment from pharmacies feels like a really nice full circle and reasonable component of our response.
So we're down to about 7 minutes. So I want to give you a little over a minute each to think about looking to the future. How can we create healthier rural communities? Are there particular policy changes, government initiatives, or things communities can do for themselves that can lead to a healthier future for rural communities? And about a minute each. So go ahead.
From my standpoint, I think from a policy standpoint, Gordon and Alex have touched on those really, really vital things, which is, harm reduction, like embracing harm reduction, capital H, capital R, embrace that, get legislation behind it, because we're doing such a disservice to citizens of West Virginia by shutting down these, making draconian restrictions on it. So I think that's definitely one thing. Expansion of methadone OTP programs, that is something that can be done legislatively, that policy-wide could make a huge impact. And then I think just communities embracing sort of the Icelandic model type things to make things in communities for youth as alternative strategies. So those are my top 3. Thanks.
One of the other thing is, I think the whole sort of community environment has a huge influence in what happens. And the fascinating thing is that in West Virginia, most of the major discretionary funding occurs at the county level. And there's even more money coming into the counties now as the drug settlement money. And we have a fascinating study where we're looking at the relationship of drug overdoses to county spending by budget categories. Sam Workman, who's a public policy person, is combing the county budgets of each individual county and whether they spend the money on parks and rec or whether they spend the money on the police force or what they spend it on. And we're looking at how overdoses may relate to changes in county spending, with the idea that we could develop a dashboard that if a county commission could move a certain proportion of their funds in another direction, this might be the predictive impact that you could have on overdoses.
Gordon, I am absolutely thrilled that you're doing this research. That is so awesome. In thinking through this response, the first thing that came to mind was using opioid settlements or abatement funds to support evidence-based approaches. So just like to Raj's point, we need to invest in harm reduction, capital H, capital R, and accessible substance use disorder treatment, and also remove these regulatory barriers that are that make this work difficult to impossible. When it comes to investing in harm reduction, I'm thinking naloxone, reducing regulatory barriers, things like syringe service programs, fentanyl test strips, drug checking services, safer smoking kits. I think that additional opportunities for rural communities can include mail-based naloxone distribution and the allocation of harm reduction vending machines. But we just need to lift some of these regulations that make some of this work possible.
I'll also make one other big thing is that the fascinating thing is we have these really high overdose rates in West Virginia overall. But if you look at across the state, there's huge differences. We have 55 counties. There's huge differences in overdose rates. And if you look at our social disparity index for West Virginia, it's all red. We look really bad. But then even when you look at the individual counties, there's huge differences between counties. So why are some counties doing well and some not? And it seems to me that's a very great area for future research.
I think there's also a lot we can think about in terms of communities and stigma. I was talking with a person in recovery in Western Nebraska, and he said, I want to be part of a community that cares for each other, because that community likes to pride itself on we're a community that cares for each other. And he said, but I also want to be part of the caring. So thinking about how communities can reintegrate people in recovery with respect and dignity, and what kind of programming, what kind of funding, what kind of work can actually support that idea of you're still an important, you're an important person, and you can make a contribution to this community. So we have a couple of minutes left, so.
One of the cool things related to your point, Mary, that is happening at a very high level in West Virginia is Governor Justice has launched this program basically called Jim's Dream. And he created this program called Jobs and Hope, which is a line item in the West Virginia budget. And it is based on the premise of exactly what you're talking about, that, just treating people is not enough. We have to support them through restorative justice to, help them get jobs. Maybe they need a tattoo removed from their face. Maybe they need help with getting their teeth. Maybe they need help with some education, get trained as a welder. So this program, the requirements are very few. You just, need to submit to drug tests to show continued sobriety. And they literally can plug you in with all of these services. If you're trying to be a welder, they will send you to training, completely paid for. If you want to go and get a master's degree, they'll pay for your school, your books, a computer, a laptop, they'll pay for all these things. So that is kind of a really cool program that's having an impact, the Jobs and Hope. And it's working with people coming straight out of prisons, straight out of community corrections in that whole reintegration mindset. So that's very cool.
Well, I would really like to thank you all for your time and your expertise. It was a great opportunity to learn about what can actually be done to reduce overdoses, and how you're making progress with those. We do have a comment in the chat that one of the challenges, and I think Gordon, your work speaks to this, is that not all overdoses are actually reported as overdoses. So the numbers are probably actually higher than we realize. But
that's actually a very good point. We just have uncovered a case where someone died, had an overdose, was admitted to hospital and died later on in hospital, and they've been signed out as congestive heart failure and respiratory distress, and it turns out they're not on the drug overdose list. We couldn't find them.
Yeah. So I want to close today by saying thank you to our panelists, and thank you for our audience, and thank everyone for joining us today. As a reminder, our symposium events are happening throughout the end of today. The full agenda is available on the symposium website. The link can be found in chat. And thank you so much. This was very interesting.